All right, welcome everybody. My name is Dr. Brian Everett. We're going to go and get started with our first and inaugural webinar here. Welcome. Thank you all, everyone, for joining us. Like I said, my name is Dr. Brian Everett, and the AAEM EMS section chair-elect, and wanted to welcome everybody to tonight's session. Be moderating tonight's. I ask everybody, please mute your mics and cut your video off to preserve bandwidth. These sessions are meant to be interactive. So we chose tonight to be a Zoom meeting. We welcome you to come to the screen to network and engage in participants if you're able. Please use the chat and raise your hand if you have a comment. We welcome and encourage participation. When you come on, please unmute or turn on your video so we can see you. And but if you want to just drop your questions in the chat, we'll be monitoring it to ask at the end as well. It's now my privilege to introduce our speaker tonight, Dr. Mark Escott. He serves as the chair, the chief medical officer and EMS system medical director for the city of Austin and Travis County. He's also the medical director for the Texas Department of Public Safety and the Texas Division of Emergency Management. He served as the interim medical director and health authority for Austin Public Health. He has academic appointments as clinical assistant professor in the Division of Emergency Medicine at the University of Texas at Austin Dell Medical School, and as a senior lecturer in medicine and public health at Flinders University in Adelaide, Australia. Dr. Escott currently serves as intermediate past chair of the section of EMS and pre-hospital medicine for the American College of Emergency Physicians. He is a board-certified emergency medicine and board-certified subspecialty in EMS. He has published numerous articles, abstracts, papers, and presentations related to EMS, disaster management, and public health. In 2019, he was awarded the inaugural Dr. Charles Bauer Texas Emergency Management Medical Professional of the Year Award by the Texas Division of Emergency Management. Prior to his position in Austin, Dr. Escott served as the director of the Division of EMS and Disaster Management and EMS Fellowship Director for Baylor College of Medicine, the Health Authority of Montgomery County, Texas, Public Health District, and Medical Director of the Montgomery County Hospital District EMS, Harris County ESD 48, and San Jacinto Community College North. In addition, he served as the medical director for EMS services and EMS education program at Rice University, which he founded as an undergrad student in 1996 after completing his training as a firefighter and paramedic. Dr. Escott, I'd like to welcome you to the screen, unmute and share your slides in tonight's EMS AAEM webinar, EMS Physicians. Is there a clinical role for the EMS physician?
Thank you, Brian, for that very long introduction. If anybody's sleeping, it's now time to wake up. Let me share my screen and I will. There we go. Beautiful. Can everybody see that? Yes?
Yes.
Perfect. All right. My hope is to talk for about 40 minutes and leave about 20 minutes for questions. If you feel like you got to raise your hand or put something in the chat, please feel free to stop me. Happy to answer questions along the way too. All right, so I'm going to talk about the clinical role for EMS physicians, but I've framed it as in terms of our journey in Austin, because you need to understand the whole picture of how we get to this stage of a real clinical role for EMS physicians. So I'm going to bore you a bit with how we got here, because it's quite a long and tedious road. So first, I'm going to talk about dropping seeds, right? Anytime you're trying to do something new, you can try telling people it's the right thing to do. It's often better to drop seeds and let other people water them and fertilize them along the way. to really make them grow. So back in 2015, 2017, I published a bunch of stuff in GEMS. Now, many of my colleagues said, Scott, why are you wasting time writing stuff for GEMS? That's not a science journal. But the answer was because that's what our personnel read. That's what our EMS personnel read. Some of our fire folks read. That's what EMS leadership reads. So it was the place to drop these seeds at the time to start talking about what this picture looks like, what the EMS medical practice looks like. So some of those talked about, how the EMS subspecialty really impacts paramedics in the whole continuum of care. Talks about, the EMS crisis and how this medical practice model can help with that issue. It talks some about the Australian system and the fact that Australia has been doing these advanced practice paramedics for more than 2 decades, and in a sort of physician extender kind of role, and how that could play in our system. And ultimately, how a medical practice can really create growth opportunities for paramedics. So I'm going to talk more about that. But first, I'm going to talk about failures. So I started in Austin in 2016, had this great idea for expansion of the program and how we're going to improve everything. And I really focused on patient safety and quality. And so I tried to sell this to city management in 2017, and they said no. I repackaged a little bit in 2018, added in the importance of and the impact it can have on resource allocation, in particular, the growth of ambulance stations and fire stations, how physicians and physician extenders could decrease costs to our community. And again, in 2018, it was a big no. Not only did they not buy into the whole picture, they didn't buy into anything. So we got no additional resources in either of those 2 fiscal years. So, again, anytime you're building something, you got to build the case. So I want to talk a little bit about how we built that case. So, you have to understand the politics, not only of what you're trying to achieve and your reasons for achieving it, but also understand what other stakeholders want. So what's the issue on the workforce side? Of course, there's a huge shortage. There has been a huge shortage in EMS for quite some time. When we look at this survey of 20,000 EMS personnel, this included 258 employers, a 20 to 30% turnover every year. So, basically 100% turnover every 4 years, which is not sustainable, which leads to obviously workforce shortages. It also impacts on patient care because we have a very new workforce, which is just renewing itself over and over and over again. Back in 2012, the Bureau of Labor Statistics estimated, 120 or so thousand personnel short in EMS at the time. So one of the big issues with our workforce shortage is this study published in 2006, where 40% of EMS personnel were concerned about the career development opportunities. So, people start out as EMTs, sometimes they start out as paramedics, but there's nowhere to go for them other than a small number of people who end up being EMS supervisors or management, sometimes leadership, chiefs opportunities roll up, but there's not any clinical advancement really beyond that paramedic level. So again, these are things that we're thinking about and how we repackage this message about this clinical practice and ultimately adding physicians into that workforce. It's also, critical when we're thinking about the physician role in the medical practice of EMS, what the community needs, right? We're all familiar with the alpha through echoes, the basic life support, advanced life support, cold and hot, and what the recommendations are for that. But when we look at some large data sets regarding the breakdown of those call types, you can see that purple section there, 43.3% are these, these cold calls. 21.4% alpha and omega, 21.9% Charlie. So, somewhere in the neighborhood of perhaps 43% of the patients that we see don't need an ambulance, and maybe also don't need to go to the hospital. So again, we've got communities who are utilizing 911 for non-emergency services. This is not a surprise to you all, but the question is, what do we do? Right? Historically, we've all said, well, these are our paramedics and EMTs. They're not doctors. They need to take you to a doctor to really sort it out. But obviously that has an impact on our community. So the average ambulance bill in the US is about $1,200, $4.6 billion a year of Medicare is spent on ambulance bills. And also it's important to understand that 40% of Americans polled says they'd have to borrow money for bills in excess of $1,000, which if you're taking an ambulance to the ER is always going to be more than $1,000. So again, understand the impact on patients. Now, why is this important? Because, for me and for many of you, ultimately the people making decisions on personnel and resources for your EMS system are elected officials. And these things are important to those elected officials, which makes it important to us as well. When we look at the cost for the after ambulance side, right, the ER bill in Texas, I don't have the average ER bill for the US, but Texas, $2,318. Again, another $76 billion a year spent in ER expenses. So this is a huge financial issue, particularly since we have, maybe 43% of patients who may be able to be dispositioned not in the ER, right, somewhere else. And this is really, the advent of the ET3 model, which helps in this discussion about the EMS clinical practice and EMS physicians, but obviously doesn't get us all the way, particularly related to the limitations associated with ET3. So the other important thing, to really build the case was this cost of service model. I've just included the information for the city of Austin because we did this evaluation and discussing the value of adding physicians and physician assistants into the field. So for us, ambulance is about $1,250 an hour, our cost to send that ambulance to each individual call. If we add a fire truck, it's another $2,000 an hour or so. But when we look at the cost of service for sending a physician assistant or a physician, it's $290 an hour. So obviously much cheaper than sending an ambulance. Why is this important for us in Austin? Well, because the city is expected to double in size in the next 20 or 30 years. So it's not just about, doing it less expensively now, but it's also a potential way for us to limit the growth of fire in EMS stations, fire in EMS apparatus, fire and EMS personnel, which are very, very expensive and not really a model that the city can afford to continue to expand like we have in the past. So certainly not talking about cutting jobs, but if there's an opportunity to limit the growth of those services while providing a better service to our community, decreasing the out-of-pocket costs for our community members, then it's a win for us. It's a win for the community. So it's great to have great ideas, but part of building a EMS medical practice is really identifying champions that can spread the word for you, right? And you all have been involved in projects before, and you have a great idea and you want to get other people to believe in your great idea. And sometimes I think we try to convince everybody at the same time it's a great idea and everybody should be excited like I'm excited about it. But that's not really the case. You have to be more strategic about that. And what we did is identify who in our community is going to be the most staunch advocates for us. And that was other physicians in our circumstance. So what we did is we went to the Travis County Medical Society and said, hey, can you help us out on this? We're trying to build EMS into a medical practice and move it away from just an emergency service or public safety entity or concept. So the conversation we had with them was, look, for physician assistants or PAs or nurse practitioners, the state of Texas says you can have 6 of those for every physician. on the EMS side, it's really infinity, right? At the time, City of Austin had 2 physicians and 2,000 providers between paramedics and EMTs, advanced EMTs. So it was basically infinity. And the discussion we had with them is somewhere between 6 and 1 and infinity should be a reasonable number that we can agree on that is appropriate oversight for the EMS system. Obviously, we have different physicians involved. This started with what we call the ED EMS Advisory Committee, which are people closer to EMS, right? It's ED medical directors, trauma medical directors, stroke and STEMI medical directors, but folks who are interacting with EMS patients all the time. And they unanimously supported that effort and pushed it to the overall executive board for the medical society, who again unanimously approved this. And not only did they approve it, they sent a letter to the mayor and to the city manager, and they sent a second letter to the mayor and city manager expressing the value of this transition, of adding more physicians, more oversight to ensure that we could do things safely. So this is really the beginning of that stakeholder process, and certainly valuable because not only is the executive board, it's 4,000 physicians behind that group that really helped us push this initiative forward. The next step was really identifying a single city council member who would really champion this effort. I have her circled there, council member, now Mayor Pro Tem, Allison Alter. Looking at the council and some of the discussions they've had in the past on things that were important to them, we have several council members that are really focused on EMS, advocating for EMS, advocating for community health. And there's several others here who were really, really supportive, but it started with one, right? And when we're thinking about how we build this model in your own system, it's finding out who makes the decisions, who has the purse strings, or who can influence those purse strings, and selling that one person and let them sell their colleagues, which ultimately she did. And again, when we went back with the proposal for expansion, it was unanimously approved by the council. One final step in terms of identifying champions that sometimes you have to use, and we certainly used as well, was using external consultants, right? Because we may be the experts in EMS, but it sounds better sometimes coming from somebody you pay to tell you that thing. So we did what we call a dispatch equity and optimization study through public consulting group that looked at this issue as well as many, many other issues regarding equity in our EMS system. But again, that report helped us build this EMS medical practice and ultimately build the budget for it. So the practice design, I want to talk a little bit about as well. So when I started here, we had we had funding for 2 physicians. We had one, me, but we had funding for 2. The things in blue are the things that we had when I got here. The red is everything that we've added on the clinical services side as a result of this initiative, building out that EMS medical practice. So 2 additional full-time deputy medical directors, an EMS fellow. I don't have it on here, but we added a 3rd associate medical director. And these 4 paramedic practitioners, which I'll talk more about in a minute. But basically, they're all PAs and paramedics. So again, thinking about that medical practice model, we have physicians at the top, we have PAs, and then we have all of our paramedics and EMTs. So really, trying to build that, not saying we just need a bunch of doctors that make a lot of money, but really making it look like a medical practice and having various levels of care available for the people in our community. So when we first tried to sell these 2 additional doctors, they weren't buying it. So we used a little maneuvering to help in that effort, right? So one of them we called Deputy Medical Director for Telehealth and Urgent Care, which really identified how that new doctor is different from the doctors that we already have, right? That doctor is going to focus on that telehealth, that urgent care aspect, that keeping people out of the hospital. The other new doctor is going to focus on equity and professional development, both issues which have been major issues with city council and certainly with our community as well. So sometimes simply adding some additional titles or additional clarity on those positions that you want help to define for folks who aren't familiar with the practice. So how does this work functionally for us? So again, we have me as the system medical director. I have Dr. J.R. Pickett, who's our chief deputy medical director. And then what we've done is we've aligned the doctors and the PAs with the shift schedule. So we have 4 shifts, A through D, and we have a doctor assigned, a PA assigned to each of those shifts. So that's their day on the street. That's their day for telehealth call, their day for command call. They'll back up on other days, and they can certainly be out in the field other days, but that's their primary day. So not only is having more doctors give us the ability to provide more clinical services in person, it also increases our telehealth capabilities. It also increases that mentorship piece so that each of those shifts have their doctor and their PA that they can go to, which not only, again, improves care for the patients we're seeing as physicians or PAs, but it also improves that education for our folks. It really sort of introduces that internship model or having that highly qualified provider with you on scene or close by that can back you up if you get into a situation. So we really see it as strengthening that whole system, not just the clinical staff or physician staff. So our EMS physicians, paramedic plus an MD. I can talk in questions if people have questions about that, but there's some reasons why we require both. They respond with an SUV. There's 2 main roles: low acuity so they can disposition, and the high acuity so they can add some additional skill set. Of course, as I said before, all calls, they can provide that mentorship, that hot wash, that expert over the shoulder like we have in internship and residency, so that you can learn from experts. That's Dr. Heidi Abraham, our deputy medical director for telehealth and urgent care. Paramedic practitioners, just quickly, these are paramedics plus nurse practitioners or physician assistants. They're about half the price of a physician. Similarly, they respond in SUVs. Similar kind of skill sets. There's some skill sets that only the physicians have, which I'll talk about in a minute. Our PAs are really primarily for the low acuity, right? We focus them on dispositioning folks in the field. So about 80% of their effort is low acuity, 20% high. For the physicians, it's flipped, because I know there'll be questions about that. So what do we see in this EMS medical practice? Again, low priority sick calls, lac repairs, abscess drainage. They work closely with our community health paramedics to really support our population experiencing homelessness. They can do medical screening exams to say, hey, you don't need to go to the ER today. I'm going to do something else for you. We also have a buprenorphine program, alcohol withdrawal program, et cetera. So these guys do a great job at those low acuity patients. High satisfaction from both our patients as well as our paramedics who, really don't want to transport these folks to the hospital because they know they don't really need an ER, but they do need some health care, and our PAs really fill in the gap for that. Again, high acuity helps with the medical decision making, critical care transport, pressure management, vent management, special devices like LVADs, those sorts of things. Additional skill sets, of course, central venous line, enhanced use of the ultrasound, but some specific techniques which our PAs and some of our paramedics can't do. Tube thoracostomies, field amputations, resuscitative hysterotomy, thoracotomy. So, this general skill set that we have in the ER, we can bring to the field if it's needed. So I'm going to skip over these. We see a bunch of patients in the field, direct in-person care. This was our first 6 months with one PA, so about 500 patients in person seen. Telehealth in that same time period, 372 telehealth visits by that one PA. You can see that all of the doctors are only doing 260 telehealth consults altogether. So again, a lot of patients seen. Our disposition rate is about 49-50%. So similar to other pilots that are doing the paramedic nurse practitioner model. So again, relatively high success rates in keeping people out of ER that probably don't need to be there. So CMS and the fee schedule. Sorry, I'm talking quickly, but I'm going to get through these slides so we have enough time for questions. So these are some of the things you also have to know, unfortunately, if you're going to build out an EMS medical practice, how all the payment stuff works. So first, what we did in our system, so our department is called the Office of the Chief Medical Officer. It's separate from the EMS department, which is separate from the fire department. So what we did is basically we turned our office into a medical practice through this application, CMS 855B. So this creates a clinic, basically, which then allows us to bill for those services later on. Now, one note on this, I know we're all kind of ADHD folks. This is not something that you want to assign to an ADHD person. This is really an OCD person's task. And I've just want to give you some screenshots of a partial list of the requirements that you have to fill out this packet. So all kinds of stuff, another page of stuff, there's other pages of stuff. It's a lot of paperwork. It's very tedious. Assign it to somebody else. And of course, we also have this Medicare enrollment application for physicians and non-physician practitioners, so our PAs and nurse practitioners, that every person has to go through so they can get a CMS number, which is associated with your clinic, which is different from the CMS numbers associated with each of the places that you work clinically in the hospital. So these are the steps to get to the billing piece, which is important, right? So fee schedules. So you've got the practice made. Now you have to have a fee schedule. So I'm going to talk a little bit about Texas. Your state may be different. Certainly, if you're working for a medical school or a hospital or a physician group, it's going to be a different situation for you. For us as a governmental entity, our fee schedule has to be based on the cost of service, right? So the unit hour cost is all we can charge for the fee. So basically, our team had to sit down with the budget office and we had to go through the direct costs, the indirect costs, and then for each item of the fee schedule, a determination of how long it takes to do that thing. So that's how we did it. The reason why that's the case is in Texas, if a governmental entity charges more than the cost of service, it's considered a tax, which you're not allowed to do. So it's limited to that cost of service, which you can see the impact here in a second. So again, we use general medical billing clinic fees. So, common ones would be telehealth level 1, 2, it's $145. A level 3 visit, $290. So that takes an hour. So again, our unit hour cost is $290. Things like lac repairs, $145. So you can see a lot of these are substantially less expensive than taking them to an ER. And certainly you don't have the facility fees associated with it as well. So generally much cheaper than putting that person in a $1,000 ambulance, taking them to a $2,000 ER. So that's the value discussion. And again, in our circumstance, that fee schedule has to be approved by council. Again, for those of you who are not a governmental entity, you certainly have the potential to generate other fees in your schedule, which are more similar to what your ER would normally bill for these services, which will generally be substantially higher than the cost that you see here. Again, even in that circumstance, if you're transporting that patient to the ER, they're not getting the facility fee. They may not get the ambulance bill as well, so it's still significantly less. EHR and billing. We're almost done with these slides, folks. So again, there's lots of EMS charting out there. We happen to use ESO. We just transitioned from Zoll a few years ago. But basically, to begin with, we started doing addendum in the charts from the EMS crews. So they turn in the chart, we do an attestation and, our portion of the examination, medical decision-making, procedures, et cetera. But obviously that's not the ideal situation for medical billing. So as of this week, we've executed a contract with eClinical Works to build out a physician and APP specific platform for us so that we can do that documentation. It's got e-prescribing, it's got a telehealth connection, it's got all the bells and whistles that we need. We can do discharge information, referrals, etc. And we're building that interface between ESO and eClinical Works so that that information can transition from ESO, the chart that the EMS is already working on, into that eClinical Works platform. And again, the other big reason for the EHR is so that we can do billing and coding to generate some revenue. So where are we on the revenue? This is a work in progress, unfortunately still. So we're in the process of hiring a consultant to come in, review the system and help us build that RCM component so that we can get bills out the door. Again, we're just in the process of the EHR, so our expectation is that revenue cycle management piece will be completed sometime in the next 6 to 9 months so that we can actually start sending those bills. We have met with some payers like Blue Cross Blue Shield. And it's probably best to say that their reaction was giddy when we talked about the value proposition, right? It's not dissimilar from the value proposition of ET3, except this includes private payers. If they can avoid that ER bill, there's a lot of stuff they'll pay for, right? And in addition to that, obviously, if you can then navigate that patient back into their healthcare system, that's even better for them because they really want to control that first contact. So there's a lot of opportunities for partnership with payers. Those are public payers, those are private payers, those are indigent care payers, because ultimately these services want to ensure that their patients are being well taken care of at a reasonable cost, and that those folks are referred back to in-network care to really try to manage those expenses and ensure optimization of their health care. So hopefully, Brian, next year I'll have some spreadsheets on what we've been able to generate. Our hope is, again, that we're never going to make a profit with this model because we can't. But our hope is that we can at least pay for the FTEs for the physicians and the paramedic practitioners to create a sustainable and a generalizable model for growth for the future. Oops. So what about this generalizability? Obviously, in a city like Austin with 1.2 million people or so, county's got close to 2 million. Having 4 full-time docs and a fellow and 3 part-time docs and 4 PAs may make sense, right? We have about a $300 million EMS and fire system together. The entirety of the budget for this office is about 3.5 million. So, about 1% of the whole piece. So not that much. But can you do this in a suburban environment? Can you do this in a rural environment? And I think the answer is yes. Those partnerships may look different, right? It may not be, the county government, having a bunch of PAs and doctors. It may not be, the rural community having full-time. But what I see is EMS medical practices sprouting up, which cover areas, obviously telehealth for rural circumstances is going to be very helpful. Suburban, depending on the size, you may be able to justify, a full-time FTE for that jurisdiction, depending on the call volume. But again, the value proposition, particularly in a time where the workforce outlook for EMS is so bleak for the next 10 or 20 years, this allows some solution, right? It allows us to take some of these low acuity calls off their hands that our medics really don't want anyway. And, plug them into healthcare in a less expensive way than traditional fire EMS models, and hopefully lead to better outcomes for our patients. With that, this is my contact information, and I'll be happy to take questions. I'm going to stop sharing now.
All right. Thank you, Dr. Esco. That's incredibly informative and definitely some information that I haven't heard before. And this is super exciting for what you're doing there in Austin. We have some questions. If you guys have any other questions, I see a couple of hands up. I'll call on you. Just to start off with, I see Dr. Harper, Stephen Harper. You want to go ahead and hop on and ask your question?
Yeah, thanks, Brian. Great talk, Mark. Very awesome stuff. Can you talk a little bit about what you see as any ethical dilemmas or problems with billing a patient for physician services when they probably did not expect, nor did they even request? I mean, intuitively to us, it makes more sense. It lowers the cost for them, but they won't see that. They'll just see, hey, I didn't ask for a doctor. And now a doctor is, billing me for coming out and telling me I don't need to go to the hospital. That kind of, I could imagine people would be upset and there might be some issues there. Can you discuss that for just a quick second?
Yeah, so I will say that since we've been doing more in-person work, particularly with our docs and NPAs, we have not run into that issue. But we're also not really sending them a bill yet. So it could come. But I think it's really informed decision-making with the patient, right? In a lot of circumstances, it's going to be 3 or 4 times the cost just for the ambulance piece. And then, 5 or 6 times the cost for the ER piece that we could handle on the scene. So the patients can always refuse. The patients can always say, I'd rather go to the ER, and that's fine. We'll send them to the ER. But, our experience has been more of gratitude of saving me the ambulance bill and the ER bill and all the time waiting to get my laceration taken care of or my abscess taken care of. So, I can certainly anticipate the concern. As a governmental entity, it's less concerning for us, particularly since there's not any profit margin there. It's just cost recovery. It may be more of a challenge if you're working for a private hospital system that is sending a doc or a PA out. But again, this I think involves community engagement. Our activity has been very public. It's been discussed and debated at the city council many times. It's been in the news. I mean, our community is aware that this is happening. It wasn't a surprise thing. So I think that helps to avoid some of that conflict of that you're describing.
Thank you. Eric and Eric Quinn and Ryan Smith kind of have a similar question. Are there protocols that trigger a PA or physician to come out and disposition and discharge, or is that paramedic discretion? And is there a dispatch component to that?
Yeah, so great question. When we first started, it was just paramedic or community health paramedic referral. And that was either for telehealth or in-person response. Now we auto dispatch. And what we've done is we've gone through each determinant and assessed an acuity level. And I don't remember the threshold that we used, but I think it was less than 10% high acuity, and that determinant triggers one of the paramedic practitioners to be dispatched as well. So as you might imagine, a lot of them are the priority 5 sick calls, but some of the things that may not be intuitive, like priority 2 respiratory, we've seen a lot of PA responses on, because a lot of those are asthma attacks that need a neb and maybe some steroids, script, and can be stabilized and dispositioned. So I think that's the process that we used. Obviously, as we're going along, we are looking at the outcomes. We are tweaking those to make the determination. But still, a lot of the referrals that we get are direct from paramedics saying, "Hey, we've seen this patient. We think they're suitable for a PA or physician in-person or telehealth disposition." So what we have now is a second tier communications group called C4, which is a collaborative communication group. So if a paramedic sees a patient and they think, this patient doesn't need to go to the ER, that gets called to that C4. C4 does a secondary triage and then refers out either initial connection with a PA or doc, or sends one of them to the call if they have in particular a procedure that needs to be done that can only be done in person.
Thank you. Katie Stevens says, I want to invite you up to ask a question.
Thank you. Thank you for this talk. It was super interesting. My question is, if a patient is seen in the field and it ends up that they do need to go to the hospital for, say, like a pneumonia or something like that, can the physician or PA direct admit them to the hospital, or do they have to still go to the ER?
Great question. They still go to the ER. In some circumstances, they may be able to be directed to a different resource. If they need a chest X-ray, for instance, they may get referred to an urgent care, but they really try to triage what the needs are and navigate them to the right place. Again, a lot of what they do is navigating those patients. If they can't take care of them, navigating the patients for what they need now. A lot of times it turns out, they navigate them back to their primary care physician. I'm sure, like many of you, we get 911 calls because somebody ran out of their high blood pressure medicine. They feel like their blood pressure's high. So that's an easy disposition. We go see them. They don't have any acute symptoms. We write a script. We refer them back to their primary care doc. Certainly, as the technology advances, we may be able to add other elements into that field, that EMS medical practice, right? I mean, everybody's seen at football games, the mobile radiology clinics and mobile this and mobile that. There's a lot of, heck, you can get a CT scan in the back of an ambulance. So there's a lot of technology that may enable the growth of this concept of the EMS medical practice that can really save our patients and ultimately as well save our payers a bunch of money.
All right, next question is from Ryan Overberger. So he says, great talk. And he is wondering if any of the hospitals have been concerned about skimming some of those patients that keep the lights on, your low acuity patients. Have you got any concerns from those?
Not really. And I'll tell you why. We've really focused on unfunded and underfunded patients for the most part. Now, we'll still see patients who have a payer source, but there's really not enough volume to substantially impact their bottom line. I think the reverse is true in some circumstances. Hospitals may be partners to help fund keeping patients out of the ER. And that's one of the things that, we still have to determine once we have that revenue cycle management going, is what percentage of our patients are going to have a payer source. Right now, it doesn't look too bad in terms of the overall picture, but a lot of them are, Medicare, Medicaid patients. A lot of them are indigent care patients. So there's certainly opportunities for those partnerships to happen, but no real pushback from the hospital systems as of yet.
Awesome. Thank you for that question, Ryan. CJ, you want to go ahead and ask your question?
Hey, thanks, Dr. Everett, and thanks for hosting. I just want to say, as the chair of the AAEM EMS section, I don't think we could have had a better first topic. Thank you, Brian, and a better speaker. Thank you, Dr. Escott. Really, Dr. Escott is the thought leader in this space. And that's why we had him here. Great stuff. I do have a question, Mark, from colleague to colleague. So traditionally, the EMS medical director oversees the medics in the system. What is the role like when you transition from EMS medical director on scene, standing back, and then you step forward and do a thoracotomy or something like that? Is it just the CMO kind of builds the clinical practice for your colleagues, or do you discuss in a group? Is it pretty egalitarian? Could you walk me through that? Fascinating, by the way, as always.
Sorry, CJ, is the question what we do as the medical practice? How is that determined, or what we do on a particular scene?
How do you delineate who you are at the moment? Like, so you miss there's a mistake in the thoracotomy, or there is some untoward outcome as you stepped in as the EMS physician versus the EMS medical director, what you were kind of initially hired for, right? Like traditionally, state statute says you're an EMS medical director. It doesn't say you're an EMS physician. How do you live in both worlds? Sorry if the question's not super clear. I'm thinking of it as I go.
Yes, that's a great question, CJ, and certainly one that has been a topic of discussion with various stakeholders here in the city. Because you're right, and Texas is, I think, a bit more clear than most other states, right? It's a delegated practice state, so it's clearly technically a medical practice. But transitioning from administrative to clinical, I think is the heart of the question. For us, at least since I've been here, we've always had some element of field response. Now, granted, it wasn't every day that we had a physician available on the street or via telehealth to connect. So part of that was discussion with our legal counsel, with our city council, with our city management, to really explain what it is that we were doing. But in Texas, the position, as you said, of medical director is there, but EMS physician is not. Our hope is, CJ, that this legislative session that will change. And we anticipate that there will be some legislation proposed that adds EMS physician and paramedic practitioner into the definitions or into the personnel within the EMS system. Why is that important? It's important because, particularly for tax-based entities, if it's not EMS, in some circumstances, you can't use tax money for it. Okay, that's number one. Number two is there's a whole host of protections and benefits associated with being an EMS personnel. And I hate to say it, if you're killed in the line of duty, it's not clear if EMS physicians qualify for some of the benefits that are available for other first responders that may suffer that on the job. So, it is one of those things I think that we need to solidify, and I think Texas has the opportunity to set that example. But ultimately, and I hope that this group would agree, ABMS has created this clinical subspecialty, and it's a clinical subspecialty with a ton of delegated practitioners. And ultimately, I think we're best served and our patients are best served by really building out that medical practice model. Certainly for medical students and current or future fellows, it's in their interest because we've got to create some job opportunities for these folks, and we have the community need that I think that drives that expansion and that need for more clinical EMS physicians. Right? It should be like an ER. You have one medical director and you have a bunch of EMS physicians. That's the way this practice really should look.
It's the future, right?
It's the future.
It's
a whole lot cheaper than ambulances and fire trucks. And it's nothing. I was a paramedic I was a firefighter, nothing against that workforce. But it's very expensive, and we are not going to be able to maintain the growth that we're seeing, particularly in cities like Austin. I'm going to give a little anecdote because I got a minute. If you go to places like Sao Paulo, Brazil, in some circumstances, it'll take 2 or 3 hours, sometimes longer, to get an ambulance. So what happens? They have a huge communication center, right? Sao Paulo's got 20 million people, huge call taking and dispatch center. And one of those consoles has a physician at it who's doing enhanced triage, and making a determination of how we prioritize these. So that's just an example of the fact that as the population grows, we cannot possibly expect to maintain this, 8-minute and 59-second response time for everybody that calls. It's just not doable, and it's not necessary, and it doesn't look like anything else in healthcare.
I think we got time for one more question. Devontae Shuford, I want to invite you to ask your question.
Hello, can you hear me?
Yes.
Yep, we got you.
Perfect. Yeah, so I'm a ER intern in Chicago. I guess I got some clarifying questions to ask
Sure.
really quickly. Is it like fellowship trained physicians that are able to take a part of this, or is it like, does it matter at all?
These are all, so all of our physicians are boarded in emergency medicine and subspecialty boarded or subspecialty eligible in EMS. Of course, you can be any kind of doctor and be an EMS physician. And in fact, I think that the EMS medical practice is probably better served having some non-EMS physicians as a part of that, right? Because if we're really want to ensure that we're taking care of our pediatric population, taking care of our geriatric population, some of our patients are frequent utilizers that have chronic care needs. Sometimes those are different skill sets than traditional emergency medicine. So I'm not one of those who says that every EMS physician has to be emergency medicine. I think it's important if you're the only person that's the EMS physician for that practice. But certainly as we talk about expanding into multiple positions or EMS physician positions, it may make sense to have some other talent pool there.
Also, just a question about, like, I guess, safety aspects. Are there any like concerns when it comes to like safety to like certain areas once you're like going to certain areas, or how does that process work?
Yeah, so I mean, part of the training is emergency vehicle operations and safety and some of those aspects so that folks can be safe on scenes. I think part of the benefit of this model as a part of the EMS system is that you have those connections with the public safety agencies, so that if you get in a situation that's not stable, it's easy to call for help. You really just press the orange button and everybody comes running. But that's part of the EMS fellowship, is really being comfortable working the field, working with paramedics, and ensuring that you can do things safely. As the boss, I worry every day about my team and getting into accidents or worse. But certainly something that hopefully fellowships will prepare folks for.
Thanks. This is an amazing presentation, and I really love this model, by the way. So
You bet.
kudos.
Well, and again, guys, as we I think mature in EMS, I think for many of us, we see ourselves less as public safety and more as public health or population health. So we really have to challenge the way things have always been. Really transporting 80 or 90% of EMS patients encountered is hard to justify. And I think we're going to see more and more pushback from payers saying that transports were not necessary, they're not going to pay for it because some of them are kind of ridiculous. So we need a better way to address the needs of our community. in a more cost-effective fashion.
I mean, this is how things are. We got to improve the professional and our subspecialty. We got to start moving it forward and growing it, like you said, maturing it as we go along. Unfortunately, we're kind of running out of time, guys. Dr. Escott, can you by any chance put your last slide up again one more time so everybody can see the contact information, so that if you guys have any additional questions, please reach out. We'll either myself or Dr. Escott, we'll get to those answers for you. I can't can't thank y'all enough for coming today, participating, asking your great questions. This was a fantastic time, Dr. Escott. I really appreciate you taking your time. So Dr. Escott, do you have any more final take home points before we close out?
Yeah, I have two things. Number one, I just wanted to reiterate part of our strategy was to show paramedics that there is a place for clinical advancement. 2 of the 4 PA paramedics that we have, paramedic practitioners, were former paramedics with Austin. And we have many more that are interested in going to PA school. So we want to keep that talent in EMS. We want to create that potential for 6-figure clinical salary so that we can recruit and retain people in EMS. So that was part of this effort. You know, the advice that I'll say to everybody who wants to do this or something similar is to be patient. Take the time to build your stakeholders, build your case, and don't be frustrated when it takes longer than you think. It always takes longer, but in the end, it looks better than you thought it could be. So again, appreciate the opportunity to speak.
Thank you so much again. And everybody, I want to remind you, we will be having another one of these coming up in the second or the fourth quarter of the year, probably around November time. So look for that coming up. Probably going to focus on some military EMS. What does military EMS look like? And then in next year, we have another one coming up where we have some more physicians. We also have the council, the section meeting coming up on October 7th at 11 a.m. Central Time. So please join us there. Again, thank you everybody for being here tonight. Really had a great talk. You guys were awesome in the chats and getting out those questions. If you have any ideas for future webinars and other peoples that are leading us in this push to improve our practice and build our subspecialty, please let me know. Thank y'all again. Have a great night. And we got it all done right on time. I'm going to stop sharing now or stop recording.